emergency medicine, especially with 7 deadly chest pains, you're all going to go, and sometimes your patients are not going to have vital signs, right? So those are the first 2 things that you're going to think of. My patient's coming in, my ambulance has already told me what's going on, but the first thing that I'm going to assess, regardless if they've got an ECG tube in, that they've already been doing codes, doing chest compressions, doing the whole gamut, the first thing that you're going to do when they throw them on your bed and you're on you is what? Hook them up. ABCs. You need an airway before you do anything else. That was one of your test questions. Airway. So if they're already intubated, how do you check that airway?
Bilateral breath sounds.
Making sure that they've got good placement. Bilateral breath sounds and else and CO2. All 4. So how do you check the CO2? Put that little monitor thing.
Capnography.
So it depends on the square. Yeah, you can do the square with the purple, yellow. Now, most places have gone up to date and have the actual leader thing that goes in there, and it's part of the monitor now. So you'll have the SpO2, and then you'll have the capnography wave. Okay, so that's what that's called, the CO2 capnography. Any questions? I hear some maybe concerns.
Oh, I was just trying. I didn't get the 4th one because it was the bilateral lung gastric bubble. Was the
Well, this is. I'm sorry. 1, 2, 3, 4. Sorry. It's just 3 different places of listening. Number 4. Sorry, it's 3. 3 things, but you're going listen, 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 check.
And when you say check, that's the little CO2 thing?
CO2. All right. And then, so you've got your airway confirmed. Breathing, as far as making sure they're still bagging them if they're needing that, or if they've spontaneously returned. Oh, yay, we've got business. Spontaneously breathing, and then circulation is chest compressions. Everybody's got all that. All right. Once you have converted during a code into a normal sinus rhythm, circulation is to be continued for 2 minutes. Because again, I know it's confusing, right? Because you're like, why?
Turn back on.
So circulation, that means if I just gave a drug and I saw it change on the monitor because you stopped, you've given the drug, you circulate for 2 minutes, and then you check, essentially, is what that's saying. Helping you in that.
Before checking for...
So once you see it convert, checking the pulse, and then again, make sure they're maintaining. So my problem with that one, I can see it.
I think...
Continue to do chest compression for 2 minutes, and then check the normal sign flow. Check and see if everything's fine. But you still need do compression for 2 minutes.
Okay.
And this is just to help you be successful in the ER, yes.
Unless completing this why are we listening to
Because not, sometimes you can have very minimal breath sounds, or you don't really get the rise of the chest, especially on the left side. You're hearing movement of air, but it may be air in the gastric. And if you've got your ET tube, if they intubated the esophagus more so than the trachea, then you're going to be blowing up their abdomen, and they're going to throw up, and it's going to hit the ceiling, and it's going to be all over everybody, and you're obviously not getting air into their lungs, so they're not getting oxygen to reperfuse their organs.
So we're just making sure that you don't hear areas. So.
Right. So every time they bag, and it doesn't happen very often, but it does. There is one time that I've been in a code, and actually, as a matter of fact, it was my very last code, Friday the 13th. Yay, had 3 codes that. I'd already scheduled it to quit. I didn't just quit because it was a bad day. That was already my scheduled quit day. But this guy was a quadriplegic and overdosed on his medications on purpose. But they had already intubated him, and they weren't getting good response. And by the time they brought him in, the first thing that I saw in the ET tube was rusty colored fluid. And I'm like, that's not supposed to be in an airway tube. And they had intubated into the esophagus, and so then he essentially, and when we extubated him, shot up to the ceiling. So guess who extubated him? Not me, because I knew it was coming. So I deflated the bulb and then had somebody else be right there. But that's why before they get there, you're already in your PPE. And I would recommend face shield. So you've got your gown, your gloves, usually the mask that has the shield that goes up like this, it's clear. And then you're fully protected for whatever may happen. Because bad things do happen when everybody's nervous. Still not? Martin? I thought we were all good. Okay. So, those are just bad case scenarios. That doesn't happen very often. I've only seen that once in my 12 years of general emergency medicine. So, again, that's not often, but it does happen. And that's why you check. Obviously, the first thing that I did was check for lung sounds and gastric air bubble. But then also just seeing that through the tube, knew that's not right. And so I went straight to the gastric air bubble, and then pressed you could hear loud. So, because everything's right there, yes.
Would you just clarify real quick what you were first talking about? Once they convert back to sinus rhythm, you continue compression to reduce the sinus rhythm for 2 minutes, and then you check for a pulse?
So, when you give a drug, when that nurse is pushing, whether it is, so let's say epinephrine, that's an epi push, and it's really fast, boom, boom. You're pushing the epi and following it with a flush. You're still doing CPR, chest compressions, and breathing for 2 minutes before you check a pulse. Because you've got to get that circulated around to where it's working. If you push, and because time seems like forever when it's going on, and you check at 10 minutes, because some people do, they get really quick, and you've got a pulse, that may have like given them a blip of a normal sinus rhythm, but it's still not circulated around the whole body enough, and then they're going to convert right back into the attack or whatever it was that they were in. So for you to be more successful, you want to circulate that longer. And again, nobody's going to be like, okay, it's right at the 120-second mark. 1 to 2 minutes. Just not immediately after you push a drug is what the gist of that is. But textbook rules by the American Heart Association, that's what they're going to want your answer to be.
Don't tell Dr. Britton.
Okay. I guess we've got a week to figure it out, right?
Yeah.
So that's the gist of the reason behind that. Okay. So just don't stop CPR immediately when you push a drug. And then also we learned with amiodarone, it's a slow push, right? And it says 2 to 10 minutes.
Mm-hmm.
Nobody freaking takes 10 minutes. 10 minutes is like a lifetime. I have never waited 10 minutes to push amiodarone. It's more like most people 2 to 4 minutes. You just need to know that whoever is pushing that is knowledgeable and skilled to know that they can't just slam it in like they do with the others. It's not a push. It's a slow push. Okay. And so there's always both ends of the extreme. But I've never seen anybody take 10 minutes because I'd be like, and they're literally watching their second hand while they're pushing it and making sure that it's just a little bit at a time. And so then again, obviously, you're gonna be doing chest compressions the whole time that they're doing that, or it's not circulating around the body and getting back throughout to the heart and everywhere else that it needs to be with full circulation. You've got to give the medications time. That's where whenever your demeanor of relaxing, slowing your own heart rate down so that you can clearly think, and watching the monitor and watching, go through your checks when something like that is being done. Okay, my airway's still good. I've got good pulse oximeter, the SpO2 is still reading good. My capnography is still reading good. That wavelength is still where it needs to be. The rise of, the compressions are good, and you're getting full recoiling of the chest. They're not just down, 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 but they're not getting full recoiling of the chest. Those are things that you're watching and just slowly going through and assessing those things. You don't have to say them out loud, but you're saying that to yourself to calm things down, as well as going, okay, we're this far into our protocol. What are the H and T's? Is there any other questions as far as this past medical history or recent history of the event that has caused this to come on? What has caused these problems so that I can reverse it? Those are the things that you're thinking while that's going on. You're just not sitting there waiting for them to go, okay, 10 minutes or 4 minutes or the amiodarone runs in. You're thinking. And you can talk to your team as well. So you say, okay, while the amiodarone's going in slowly, we can't assess on the monitor their return of a normal rhythm until it's circulated long enough. And as well, until that medication is completely in. So let's go through the H's and T's. What have we already covered? What have we already thought of? Well, so when I said checking the airway, oxygen, that was one of your H's, hypoxia. If that was the original cause, we've already corrected it, and it is still corrected. See, and I've already started doing that just by talking through those things with you. So, hypoxia. What's his temperature? Did anybody get a core temperature? Was he outside in the cold weather? Was it a possible heat stroke? Those things. What medications is he on? Is he diabetic? Are we looking at an acidosis? Do we need to look at utilizing something else like bicarb to help him respond to the medications? If he's acidotic, he's not responding to any of these drugs that we're giving because his pH is too low for his heart to even respond. See how those H's and T's jump right in? So one of the H's is, I always just think of the H with a plus, hydrogen ion acidosis. Is that how they listed it on there? So those are the things, that's your thought processes. And then, of course, your OMI is how you're setting them up. So these are all the orders that you're spatting out to your nurses as they're transferring him over. Once you have gotten the airway, somebody's on their chest, obviously we're making sure that they're on our monitor. Mask pants are only going to be for trauma. So it's just that mnemonic of thinking, I'm freaking out, we don't have good vitals, patient's unconscious, I'm going to go through this mnemonic and this is how I'm going to think so that I can cover everything, all right? You give up, that's fine, we're just going to wing it. I'm going to look at this. Are you guys able to pull it up on your computers? Yeah. We'll just do it the old-fashioned way, but still not as old-fashioned as the way I was. We didn't have any of that. All right. So everybody has a card? All right, we're going to start the flip classroom. So don't be flipping through, forwarding through the slide yet. Who's two apart? Give me one of the, without looking at your slides.
One objectives.
Okay. One of the causes of a deadly chest pain that would present to the ER. Name one of them. Yvonne? Okay.
Acute MI.
diamonds? Give me another. Good. 6 of clubs.
Oh, it's in, that thing, one collapses. Engineering.
Okay. So pneumothorax, and that could be tension.
What was that?
So we're going to change this to PTX. That's the abbreviation, so that I'm not using all my room. But if you guys forget what that is, you can ask. 3 of clubs. What's the other type? So she said tension. What's the other type of pneumo?
Pneumonia?
No, pneumothorax, I'm sorry. You can have a tension pneumothorax or a
Yes, it.
spontaneous. Sorry.
It was the basketball player.
This is the one that's going to kill you, though. You don't figure it out. This one can, but only if you screw up really bad and miss it and send it home.
Oh crap, what is that second one? Number 2.
Pulmonary.
Everybody got that, or is there a lot of confusion there?
No, there was a story that we heard about a basketball player for
Red
spontaneous.
Okay. 5 of clubs. That's a club.
That's a club.
That's me. Puppy feet.
Oh, that's not my club.
Yes,
This is gonna be.
Yes, I don't know cars. I'm sorry. I'm a huge cars player. I'll do for the next one. This is like my great grandmother. Yes.
Okay.
Because there's lots of chest pain. I want the deadly ones, because these are the top 7 that you're going to rule out first on your differential when you got somebody that's coding or somebody that's presenting in chest pain and they're looking bad.
An aortic dissection.
Very good. They're like, oh, that was mine. Sean. T-A-N is also Sean in my language. For anything. 3 of spades. The other 2 are hard, because I actually tested myself 3 days ago before I looked at this lecture again. And I would listen. So, don't feel bad. And 9. Next 2, you guys get these are rock stars. 5 of hearts. Oh, shoot.
What did you tell me one earlier?
What is another presentation of chest pain that can be deadly?
Heart failure.
Huh?
Heart failure?
That was my guess, but it wasn't one on there. That's going to be your PDO.
Pneumonia?
Yes,
Ooh.
pneumonia. Right? And you want to fix the hard one, right? Do you want a Maxwell's or a Pinlight? That's all I got. Oh! Well, I'm not going to give this out. It's $20.
Penlight?
Yeah, no, we'll take a Pinlight. All right. Black or white? Black one's the white. All right. 10 of spades. All right. Can you think of one other one that's on the list? Oh.
Esophageal rupture?
Yeah, did you look back? I wouldn't have thought of this.
So, did you have an esophageal rupture from Barrett's esophagus, like varices?
Good. So we're going to go through that. Don't give out answers.
Is it
We're not done.
spontaneously ruptured?
Good. Or
Was pneumonia one of them?
pneumonia. Oh, I forgot to put it up there. You're right. I was like, I thought we had it. I would put CHF up there too, but that's not gonna kill you really fast.
What about anaphylaxis?
You can't breathe, what are you
That's not chest pain. So these are the 7 that we're gonna go over. And then this is gonna be your PDL assignment. All right, so. 7 of diamonds. Somebody give me the presentation of what this patient's symptoms are gonna be when they come in.
Which one are all?
Oh,
The first one. So
Yeah,
obviously
chest
chest pain. They could have like neck pain or shoulder pain,
right.
swelling.
Diaphoresis.
Yeah.
So this could be neck. You said
Shoulder.
shoulder. Okay, so diaphoresis.
They
Yeah,
could have
tachycardia. Could be tachy. Most of the time when they're panicky, if it's really bad. What are your hallmarks? Think of your big 8. So chest pain, diaphoresis, tachy,
trouble breathing.
right, shortness of breath. Those are your main ones. Sometimes they're going to be pallor or gray. Sometimes they're going to say, I'm dying. They're going to be anxious, scared. Believe them. You're going to start being able to recognize what an MI looks like just from seeing that patient. It's amazing. Before they even tell you they're in for chest pain. All right. Good. So we're going to work through this one so that you're not having to switch gears. That's the symptoms presentation in that. Now, what's the first thing that you want to do? Let's say that this patient wasn't brought in by ambulance. They just walked in and said, I'm having chest pain. So, let's do this. Sorry, just so we can play this game. 6 of hearts.
That's me.
What do you want to do?
Didn't
Okay, so, first off though, you're not always going to, you're going to order that, but what would be the first thing that you would want to do if you were to go through this?
Like their airway and their breathing. And
So,
check for pulse.
okay, you checked his airway, he's breathing on his own and it's patent. Somebody said it.
Starting on oxygen.
So, put him on oxygen, so you're going to go straight to here, right? What was O? Sorry, I skipped that. Oxygen, and then what? Monitor. Good. So monitor. Let me go to the next card, sorry. 8 of diamonds. What else do you want to do? Yeah, so that's going to go under circulation, good. IV, and how do you, what are you going to say? Good. And normal saline. And for right now, you haven't listened to his chest, and so right now you're just getting those established and we're moving to the next thing. Yes.
So if someone walks into the ER and says, I have chest pain, you're going to start 2 IVs without doing anything else? Okay.
Yeah, because if they're having an acute MI and you're, you give them some medications, but then they go into VTAC and you have to run a full code, you don't want to start all back over again and go, oh shit, instead of oh my. Yeah.
EKG, like no triage or like where does EKG triage like?
So somebody says that they're getting, in triage is in a room and they're sitting up. So they're not on a gurney or anything, you can't do an EKG on them there. But as soon as they say, I'm having chest pain, or if they look like the gray and they're walking up to the table and doing this and saying, I'm having chest pain, the nurse stands up and walks into the room. You get a free, go to jail, don't pass 200.
That's what I was.
Yeah. So, The next was EKG. I don't know who said it, but that's what you're gonna do next, all right? So those are the main top things for spades. So we've done oxygen, we've done monitor, we've gotten the IV. This is what the mnemonic, you're going down here now, all right? See how that's working? Who was 4 of spades? You are? Oh, I'm sorry.
So, do you say I need 2 or more IVs, and then they know that if they can't get an IV started, they do an IO? Or
Correct.
what do you like,
Yeah.
IV IO?
No, you won't say IVIO automatically, you would just say 2 large bore IVs, and then they're gonna be communicating, because you're all standing there with a patient, and they're like, I can't get an IV access over here, can you over there? Because you've got 2 nurses on either side, one on each side, trying to start at the same time. And then they're communicating, if neither one of them, it seems like they're peripherally clamped down, most of the time that patient's not gonna be conscious before you do an IO. I've never had to do an IO on an adult, unless they were completely like out or trauma.
If they come in with paramedics, they've already started the 2
Right.
large bore?
Right, but this is not.
Oh, I didn't know if they had.
Most of the time, yes. And if they don't, then you say, I want another IV access.
Okay. So I didn't know if that was protocol for them to start with too.
Yeah, most of the time it is protocol. But again, maybe they had a really bumpy ride or something happened and they only got one and they had to go to something else because it was more urgent. So those are the things that you're checking. So if they were brought in, then you say, do I have 2 IV large bore IV accesses? And what are the fluids running? Okay. So, 4 states, did that person answer?
What was the question?
Who is it? Okay. What's your next thing that you want to do? So we're at oxygen, we've got them hooked up to the monitor, we've got 2 IVs, and we've got an EKG. Right, so what do you want to order?
Monitor pads and EKG pads.
Okay.
CBC,
I think Jesus knows the same thing.
CNP.
The heart monitor, like what we give for Saturday.
You say,
X-ray.
what did you say after PTIR?
But we were looking at it.
Very good.
Mm-hmm.
Oh, that's next person. 7 parts, hopefully they didn't hear you. What's the next thing you want to order? Who's 7 parts? Okay. What's this? So she's ordered the labs. What's the next thing you want to order? This patient's having chest pain. We've got an EKG and we've got the labs. I know this is behind everything, but the labs were troponin, CBC, CMP, PTINR. Did I get everything written down? Yeah. What'd you say?
I think that's everything that you order for the lab.
That's all for lab. What's the next thing you want to order? She says.
Oh, for the B, divide the sign?
That is, you skip because you're here.
Okay, so that is, so the, for the tube, you mean the tubes?
There's no radiology in there. What, if I were to say you need to order something radiology-wise, what do you want?
That is chest
Just a please?
So, chest x-ray, and this patient is not really stable to go to the x-ray department, so what do you call that?
Bedside X-ray?
A what?
A bedside X-ray?
It's called a portable chest x-ray. One view. Because the patient's not going to stand up out of bed and turn and do all that, okay? So the way you'll write that or say, chest x-ray, one view. And they'll know if that's,
Does that happen with everyone with chest pain?
yes.
Like the portable version, if they can't, only if they can't move, I guess?
You do not want to unhook him from the monitors and everything because, especially if your EKG is showing us the elevation, right? And yes, you want to do a chest x-ray, because not only could they be having an acute MI, they could be having an acute MI because secondarily their congestive heart failure is worse. And you listen to their lungs and you can hear it, but you want to confirm it's chest x-ray. Now, if they're so unstable with the vitals, there's going to be a point in time that you guys can move out of the way. You're not in the middle of a code. They're still going. They can get in there and get it portable with everybody at the bedside. Obviously, you guys will step away as they click the button, but it'll be a very short moment in time. All right? So what's T? Twos. So 5 of spades. Is there any other tubes that you would consider at this point?
Besides the IV.
Right, that is a tube, so making sure that you've got IV access, yes, we've gotten that. So now the thing that I would think of is, do I have fluids going? Have I assessed this patient enough to know? So I've assessed this patient. He is having an ST elevation MI. And so we are, well, regardless, rural or in the city, what would you need? Because in the city, they're going to be going where? Cath lab. And rural, they're going to be going to a cath lab via helicopter. And either way, they're not going to be able to relieve themselves. So you've got to take care of that. So tubes. So you have to be a captain. And you're going to order that. And again, the patient is stable. You're not pushing into medications at this point. So that's, we've helped whoever had 5 of spades out. I'll give you another. So, holy cow. All right. This on the acronym on the slide, as well as Dr. Lovelace actually put those together as vital signs. I use that as the next thing you're going to need is a specialist, right? So, specialist, once we get there, I'm making a phone call, and I'm usually doing it right after, once we've gotten the labs back and the EKG. Because my specialist, the cardiologist, wants to know what's going on with the EKG, and if we have any labs back, what is the main concern with a patient having an MI, 5 of spades. What is the cardiologist going to want to know? Not only what the EKG is, but what labs is he going to mostly be concerned with? Right. What specifically indices, which are the specific tests within those big orders that he's going to ask you about.
Like the level of the troponin.
All right. What's your troponin level? He's going to ask that. I don't have it back yet. What else is he going to ask?
What's their reading?
Right, PTINR. He's going to want to know that immediately. So if we don't have a PTINR yet, because we're in rural Blackville, America, and there's only one lab tech on, and she also had to draw the blood. What else would you be looking at to kind of give you a precursor of what that PTINR might be?
Numbers.
Right, good.
What?
Medication list. What medications are they on? Are they already on a blood thinner? Yes.
Can we kind of like repeat a couple?
Sure. If you guys can't hear anything, I'm sorry. Yeah, just speak up, definitely. Project. So we're talking to our specialist. The cardiologist is on the phone. We've explained what our EKG is showing. He's got ST elevation in the lateral leads, 2 millimeter ST elevation, so it's definite. As well as our patient fits the picture by far. So he's got that knowledge. The next question he's going to ask, and Bethany says, what's my troponin level? He's going to want to know that. Well, we don't have that back yet. So what's my PTINR? What are his coags, is what he's going to say. So then you're going to give them that result. Well, if we don't have the PTINR back yet, what else could we look at to kind of help know one other lab to kind of help us know his status as far as bleeding?
CBC?
Which indice with the CBC?
RBCs.
Platelets and
RBCs. Red blood cells.
H&H, hemoglobin hematocrit level. So that you can know whether or not he's already in trouble, already has a chronic condition that's going to predispose us to having complications of bleeding during surgery. Okay. What if we have no labs back yet? What's the first thing he's also going to ask? Not, well, we've already talked about the EKG. Vitals. Vitals are extremely important. So you may have rattled them off when you very first presented this patient to him, but he's going to say, tell me again, what's his hemodynamic stability? And that's going to be, what, 2 vitals?
Blood pressure.
Blood pressure and heart rate. Okay. So that way you'll know how to answer those questions, because those are the questions they're going to be rattling back. And you're already going to be nervous, especially if it's the first time you talk to the cardiologist for consult. I'm just kind of giving you precursors to help you to know the language that we're going to speak and what the expectations of what they want to know immediately. All right? Okay. Good job. We've done 1. Ten of Hearts. Now our patient came in and we're suspicious of a PE. What are the symptoms going to be?
Recent, like history of recent surgery or.
Okay. I was just put HO. Surgery.
Well, the chest pain.
Right, chest pain obviously.
Difficulty breathing.
Absolutely. Shortness of breath. What's another history?
Hospitalization or inactivity.
So, right, sedentary or bedridden. What if this is a 45-year-old who just came back from vacation? What do you think?
A long flight.
Right. So, long travel, whether it's flight or sitting down in the vehicle and not getting up, stopping enough to walk. Good job. Good do that. 8 of spades. Me. All right, so, what other risk factors would you be thinking of? Birth control? Good. So that goes with the history as well, so.
What'd she say?
Birth control. So we're looking at meds. UCP, birth control pill, or any way of birth control.
Recent baby.
All right. Who's talking to me?
The second one?
Is that what I thought?
Am I off now?
I thought that was your voice, but then I didn't want to be, wrong. I'm looking at the wrong person. Nine of diamonds. Anything else as far as etiologies of what might have caused that?
Hypercoagulable state.
Right. So hereditary disorder. Do you have a Maxwell's and a Pin line already? Which one do you want?
Headlight.
Black or white?
Black.
Those were the only two colors they had for me to choose from. It also has a little pupil thing, so you can learn the size of pupils. Thank you. So what'd she say? Alright, listening, good. Oops, spelled wrong. And those disorders are, hold on, 4 clubs.
Last one.
What'd you say?
Pregnancy, factor
job.
5, factor 5 vitamin deficiency.
Good job.
Oh yeah, protein S.
Good. Those are your most common ones. Protein S, and cardiolipin antibodies would be medical tests also. Tests for that.
Will you repeat that, the test?
Cardiolipin, cardiolipin antibodies, depends on how they pronounce that. So obviously, if it was a female and she was of childbearing age, you're going to make sure that she's not pregnant. Most of the time, though, it's somebody that's far enough along that they're showing. But still, immediately your blood volume changes and you start developing and producing the placenta and all those other things. The state changes almost immediately. All right. Oh, one other big one. 2 o'clock. Give me one other big pre-existing condition. Pre-existing condition that could cause a PE.
Smoking.
So AFib can cause a stroke, but then also you can cause clots, but even more so.
What about like atherosclerosis?
Not as much. That's usually your MI. There you go. So recent trauma, fracture, or surgery, like even with the long bones, the pelvis and the long bones. So I was in a car accident a month ago where they had to really, fixate my femur. And, with that, the recovery, you're going to be immobilized for a while. So that's 2 things right on top of one another. So, absolutely. So recent trauma with a fracture of a long bone. So you've got femur and pelvis are the most common. Okay. How are you going to treat this? So let's go on to, we've already done the EBCs and we're here. What labs do we want to evaluate? 5 of diamonds.
Labs. Let's see. I know we get a picture of the lungs at some point.
So chest
I can't remember
X-ray?
what that one's called. Well, it was something more specific.
PQ scan?
There it
That's
is.
really old.
That's it.
What's the new hallmark diagnosing standard of care to diagnose a PE? Actually, I think for the test, you guys are going to get a board review right before you take your boards. That is one question I would freaking ask right before the boards, because you never know what the answer is going to be. Because it used to be a VQ scan.
Yeah.
It ain't still anymore. Perfusion ventilation scan. Now it's guided with CT, but our main thing that we usually do is CT of the chest. Okay. But you need to ask them when they come and do your board review, what is the answer for now when I'm taking my boards to that question, because more likely you're gonna get it. Which really confuses us, because in real life, we know what we do, but it's different than what's on your test. Which I think is ridiculous. They shouldn't be able to ask those questions when there's so much controversy. All right, so we're just CT or VQ scan. We'll just say both.
What's the answer for the board though?
You're gonna have to ask that on your board review, because that's gonna be a whole year and a half away. And so I wouldn't worry about it right now. Yes,
Your PowerPoint says that angiography is gold standard.
so CT angiography. There you go. But again,
Yeah, okay.
ask for the board. Because I know that I've heard a PowerPoint recently that had that, and I'm like, I thought we did away with that years ago. And then we had this long drawn out debate. CT angiography. CT angiogram, however you want to say it. And then what's the next thing you're going to do? Because beyond that, you're probably not going to be pushing meds, and you're definitely going to have specialists in on that. So now you're calling the specialist. We're here. 8 of spades. What's that specialist going to want to know? Who's 8 of spades?
Me again?
Is that the shovel?
No.
No. I said spades. I meant clubs.
Oh, okay.
8 of clubs. I'm like, how'd that happen?
That sounds good.
All right, Shannon. What is your specialist going to want to know?
Vitals, oxygen.
So he's going to want to know vitals. What's our SpO2, so that I know how severe we're being affected. May have this back, may not. They may be actually in there, because I'm going to call them early on, because I'm going to get them accepted to transfer them out of here. But then, as far as the stuff that we've already talked about, what are the things he's going to ask?
Meds.
Meds?
And that history.
Good. So this is going to be big. So make sure you have the answers before you make those phone calls. And if you don't have those answers written down ready to answer, then you better go and ask the family. So history, make sure if you forgot to ask the patient, make sure you're asking any recent surgeries, any history of an EVT. And it doesn't really have to be recent. Recent is a biggie to know if it was recent, but history at all of an EVT. And obviously all of this stuff. Hypercoagular mistake, and then this. So you're going to need to know all of that so that you're not like, oh, I forgot to ask that. Okay? All right. We're done with that one. Next one. Tension pneumo. 3 of diamonds. How's that patient going to present?
Chest pain. Short breath.
Shorter breath. So, a PE and a tension pneumo, these patients are very anxious. They know they're fixing to die. A PE especially too, they are hard to, because you go through the whole thing first because you don't know, are they having an MI, are they having any of these other 7 deadly chest pains, so you go through the oxygen, you get them on the monitor, you're getting an EKG, you're starting IV, you're giving them some fluids. Pain medications sometimes, so you're given nitro if it's an MI, they've got really, really high blood pressure, you're probably going to give them nitro sublingual to kind of see if you can relieve. That's one thing with an MI, we forgot what. That's a nitro. I didn't do that. So what what are the things that you're gonna do? Pulse oximeter was less than 90, so you're making sure they get oxygen.
I had a quick question, sorry. Going
Sure.
back to PE, do you do D-dimer? I forgot. I know they do.
Yes.
Okay.
And D-dimer definitely.
Okay.
Well, and some say yes, some say no.
Right.
Some say they don't want to use them anymore, that's why. And it's gonna be dependent on what your protocol is and what your specialists are gonna want to know. More than likely, they're not even gonna ask anymore, because the pulmonologists are gonna say, I don't give a shit about that. But then you're gonna have primary care doctors that are in rural Oklahoma that are still doing it, so. Do what your supervising physician wants you to do, and don't argue with that, and then just make sure that you're prepared, and that's when you're gonna, develop those relationships with the specialists. You're gonna have a set of pulmonologists that you call, and cardiologists that you call, and usually there's gonna be 2 or 3 out of the ER, just in case one's not on. But as far as the PE and the MI as well, you give them pain medications. And this will be on my slides real quick. Once we take a break, we'll go through the slides. So again, for MI with pain control, what do we use?
Penicillin or Dilaudid?
Number 1 is nitro. You're going to bring their blood pressure down, because a lot of the times nitro will relieve their chest pain if it's cardiogenic. If nitro doesn't work and they're still having pain, then we go to the Dilaudid or
Was it
fentanyl.
fentanyl?
And Dilaudid is my choice. If they still are not getting pain relief with Dilaudid, then I move to fentanyl. But a PE or tension pneumo, you're not going to be able to relieve their pain, because it's the PE and the tension pneumo that's causing them, okay? So a PE, when they're having a lot of pain, they're going to be thrashing all over the bed. They're going to be very anxious, moving, not able to sit still. They know they're dying, something's wrong, somebody needs to help me, and then they make you anxious because they're acting like that. And nothing that you do before you can figure it out on the EKG, because you don't know if they're having a non-ST elevated MI or the PE. What the heck's going on? Why are they not responding? Their blood pressure and their pain is not being controlled by nitro, fentanyl, or that Dilaudid, fentanyl. Still no relief. That's when you think PE along with that. Your tension pneumo, on the other hand, what is the physiological reason they're having a tension pneumo? Six of diamonds, I can't hear anybody. Who's 6 of diamonds? Okay. So what's going on with the tension pneumo?
Is that the one with the biggest hand?
Yeah.
So they're vena cava scheme?
Right. So something is causing so much pressure buildup that it's moving your cardiac silhouette and your trachea to the side, because it's building up pressure. And what is that usually?
Air.
Air where?
In between the visceral and the parietal.
Right. So in the lung spaces. So outside the visceral, which is visceral is on top of the organ itself, and then parietal is outside, and then you've got that space in between. So usually you can't see it, and a tension pneumo, you're gonna see it because it's continuing to expand and then pushing your lung tissue, which is visceral, into the heart, and then pushing the heart over. And it's just, as you would think, causing that pain because of that pressure of your organs being pushed over that's not supposed to be, as well as getting short of breath, worse and worse and worse. Okay? So, 2 of spades. What is the true etiology? That's the physiological reason. What could be a possible etiology, or what's caused that tension pneumo? 2 of spades. You again? What am I
Who
doing?
gave me 4 cards?
Who did? Oh, you got the last of them?
Yep.
I'm gonna say blunt force trauma.
Okay. So getting hit in the chest with a pipe. Somebody beat the crap out of somebody and beat them with a blunt object. That would be one cause. 8 of hearts.
I mean, like a broken rib, which I guess would go with the trauma.
Well, we're just saying what different types of trauma would you want to expect and make sure you rule that out. So fractured rib would be more of like a sucking wound causing the tension pneumo, right? 4 parts.
Like motor vehicle accident.
Very good. Car accident, most common cause. Yes, did you have a question or you just said excuse me? I didn't pay attention. Excuse me. 9 of clubs. What is the number 1 mode of treatment to fix that the fastest?
That's me. Well, you need to release it more, so I don't remember what it's called, but chest tube.
Right, so you did the motion.
I
so
knew. I knew
Insertion
it
of a
was
chest
right.
tube would be 1. What if you're out in the field and you don't have all of those modalities and it's just gotten started, so the patient was having shortness of breath, and it continued to get worse and worse and worse. What can you do? Right. So needle decompression. So that's the easiest, fastest when you don't have a whole lot. If you don't have a chest tube thing, shove a needle in there. Get some of that pressure off, as well as the fact that you're going to have increased or decreased risk for causing a collapsed lung.
It will cause one.
You have to have a tension pneumo because there's air there, right? So that lung's already pushed away. You could, if it's not completely collapsed, if you go too low, but then you're getting into like puncturing your heart and everything else, so you just don't want to do that. Obviously, you're going to put the needle on the side of decreased breath sounds or
Decrease.
right. So you're going to have decreased breath sounds, not increased. So the lady that I came up on a car accident going to Stillwater that got T-boned by a semi right in front of me. What was not only the decreased breath sounds and her stressful situation of getting more and more shorter breath, 3 of hearts, give me another physical exam finding that I knew and confirmed that that's what was going on.
Displacement of her trachea.
Okay, that's not the one I was thinking of, but very good. She actually didn't have that yet, but good answer. 10 of clubs. And I don't know, maybe we haven't really given you this. You guys have had a lecture on tension pneumos, have you? Okay. 10 of clubs, puppy feet. You again?
DM has the answer.
DM has the answer, what is it?
Your blood pressure?
Nope. So I'm out in the field, I didn't have blood pressure.
Oh, you're not previous.
Because I came up on this accident, and all I had was
Oh,
my stethoscope.
fellowship.
Yeah, we've already gotten that. Subcutaneous emphysema. People know what, you guys know what that is? Yeah, Rice Krispies. So you push on their skin, because it literally is like coming out of their lung space area and going into the surrounding subcutaneous tissue. So that air is like bubbling up into the subcu. And you push on it and it feels like crinkly paper, but then it also sounds like Rice Krispies. And so immediately, yeah, that's what's going on. Without any other, I didn't need a chest X-ray or anything else going on. It's pretty impressive. That's the only time I've seen that. Yes.
Can you hear that grossly, or do you have to have your stethoscope, kind of?
It's louder with the stethoscope. I could feel it more than I could hear it because we were out in the field. I don't know, if you could really, I guess maybe if you put your stethoscope and pushed, it would be more like Rice Krispies. I just knew from the way it looked, and when I pushed, just that feeling sensation was like, oh, yeah, that's what they're talking about. So, it's pretty neat. Some of those things that we learn in the books, you don't really have that full comprehension of what it is. And it may not be exactly the way it was listed in the book, but you know that's what it is, and you're like, there's no doubt that's what it is. So when you come across those things, that'll be amazing. So did everybody answer? I feel like I skipped.
I haven't answered.
You didn't get the answer? Anything?
Did you skip me?
All right, so spontaneous pneumo. What are the, what is that patient's characteristics it's going to have? What is somebody that's going to have a spontaneous pneumothorax, which means it just occurs because they sneezed or they coughed? What are the characteristics of that patient that is usual to be high risk of developing those?
Tall and thin
Tall, thin,
and younger.
young, male or
Athletic
female?
males.
Male or female, more common?
Male. Female.
Maybe that's.
If I got
Maybe
this, I was
wrong.
right.
Maybe we need to look that one up.
I don't know. Just the example that we were given was a male, so I kind of.
Gotcha. Smokers as well. So that's the other risk factor. In that. All right.
Okay.
You guys want to take a break? No? Ready to go? Is that the consensus? Yes, sir. Is this helping you guys to think logically how you're going to do this in the ER? Like the way I'm presenting this, because this is a new thing. Nausea and vomiting is usually going along with what as well? What, one of those that we've already talked about, MI. Very, very common. An acute MI, nausea and vomiting, is one of another common presenting symptom that goes along with the others. It's not just nausea and vomiting. All right. Now we're at the fourth deadly chest pain, aortic dissection. We're going to go a little faster. 8 of diamonds. What are they going to look like? What presenting symptoms?
What's the time? Some like abdominal pain, that raise with like, maybe hypertension.
Okay, very good. So she's got pulsatile abdomen, or over the aortic area. Chest pain, she said. Definitely, that was understood. Hypotension. All right. What is a hallmark symptom? It is textbook of aortic dissection. Tearing sensation. So make sure that you know that, because that's how it will be presented in your vignette on a board question. Tearing sensation or ripping in my chest through to my back. From shoulder blades, they like to say that as well. All right. So 3 of spades. That's neat. What are the labs? Uh-huh. you're gonna get that because you're also gonna order before that, because you've got chest pain that's ripping through the back. Every one of these 7 chest pains, you're going to definitely get a what? EKG on everybody, okay?
I was gonna say, I don't know if that's what we're allowed.
I'm sorry, we're throwing it
Special
all in
test
there.
lab.
Lab x-ray, because there's no, on my mind, it's not in there, but you better not forget it. I don't know why they didn't put another letter for that. So I guess labs or orders. Yeah. So what would be the other thing, if you were having a high suspicion of an aortic dissection, what is the one lab that you want to make sure, along with your CVC, your PTINR, your troponin, because you don't know if it's an MI yet, your EKG, your chest x-ray, your PTINR, I don't know if I already said that one or not, your COAs. What is the one lab? We're dissecting through our aorta. What are we going to die from? Ruptured aorta being loss of blood, which means what does the lab need to be doing?
Cross-matching type thing.
Type and cross-match. Okay. So we're losing a shitload of blood at a rapid rate. We're obviously going to be fluid to hemodynamically stabilize this patient. And before we have the blood ready, we better be ordering that type of cross-match, which takes forever. But what are we going to have on hand, 7 of parts, to be the first bag of blood that we give before we have a specific type of cross-match if we need it? Does everybody know? The universal donor, 7 of parts. Say it out loud.
Oh, excuse me.
Okay. What's the universal?
The type.
Blood type, what is it?
Oh.
O. O what? 50-50
Negative.
chance.
Negative.
Good. Why negative? Negative means there's no or antibodies. Yeah. The RH factor definitely, so especially in a female patient. Not so big of a reason to not get O positive to a man. So if you don't have O negative, then your next would be O positive. But, all right. Good. I just need you guys to know those things.
So if it's a woman, you would do RH factor too?
You just go negative because you
The
don't want to
lab.
accidentally give her the antibodies in case she gets pregnant.
So you ordered the type and cross match,
And
so
then
you're
after that,
essentially
if
on
you
the order, you're
order,
gonna say, type and
That's
cross
part of the type
match,
and
2
cross
units
match.
and hold, be ready, stat. And there's no type and cross match stat, but that just means you better do it as fast as
It's
you
just
can, because I
on
need it as fast as it's ready. That's what that means. It takes a while. And then, so your fluids and your pressors, what are the 3 pressors that we're thinking of? 8 of spades, lady up there. Oh, it was
I'm
you.
the shovel.
She's the shovel, you're the puppy too. Sorry, she's got all of it. What are the 3 pressors that we've really learned and that we really need to work with? Levophed. Yeah. Grab the dope, that's the one thing that I always think of. Dope, get my dopamine or my dopamine. And those are the 2 that I go to first, and then Levophed. Levophed, and this is the way I would think, you can ask your preceptors. Levophed is one that is very, very strong and very effective, but you better have your specialists right there handy if something goes wrong. And when I'm in the middle of nowhere, I didn't, so I used the ones that were a little safer.
Can you repeat the 2 you used before moving?
Dope, dopamine, dobutamine.
Okay.
So think of Homer Simpson. Dope, dope, so that you don't have one of those moments. Okay. So their blood pressure's dropping. We're cranking first. The fluid's wide open, whatever fluid it is. Not talking about a pressor, just IV fluids. Open them wide open, and then get your compressors ready. All right. Cardiac tamponade. We're pretty much repeating ourselves with all the other stuff. So just understand that your presentation is almost going to be similar. Make sure you're thinking of all these things. Yes, you have 2 questions back there.
Well, can you repeat which vasopressors to use one more time?
I use dopamine first, then dobutamine. And again, it depends on the type of patient that you have, whether it's a pediatric or an adult or if they're congestive heart failure, but that's for later. But those are my first 2 go-tos.
I guess I'm just confused on the dobutamine. Because it vasodilates, right?
Right, but you will learn when you come back from Thanksgiving from an extremely intelligent gentleman, Matt Burtis, that has done cardiology for years. And so initially, that's why that's my second choice, not my first. Dobutamine does vasodilate, but at a certain rate and bolus, it does the reverse immediately thereafter. And he will explain all of that. I am not physiologically accelerated in my experience to be able to explain that. He will. And yes, that's definitely been a question that has been brought up during his lecture, because he goes over pressors also. So he will teach you definitely on that. Okay? Sorry. To be continued later. That's what you call that. All right. So with cardiac tamponade, 9 of diamonds. Have you already answered the question?
Yeah.
The second time around? You just now did? Okay. 6 of diamonds. What do you see on an EKG with cardiac tamponade?
Wait, now we're on 6 of diamonds?
Uh-huh. Do you want me to change somebody else?
Sorry, I was confused because I thought you were going to answer. Okay, wait, what was the question?
With cardiac tamponade, what do you see on an EKG that kind of gives you a hint that that's what's going on? Ask a friend. Ask a friend. What's it called?
Like really tall peaks.
Olivia.
You say low voltage activity. I don't know how to.
So it's actually both. Both of you are right. But it's called pulsus alternans, so it goes big, little, big, little, big, little. Pulsus paradoxus is the other name for it.
I think it's electrical alternating.
Okay.
You could
And that again is because of all that pressure. It's, you know, sometimes it's getting better perfusion than others. All right. That's the main thing with cardiac tamponade. What would you treat? So if you had, what would be pushing on the heart, causing that? Fluid or blood. So sorry. Get better. I'm like, oh, I second guessing myself at the last second. What would you do to treat blood in the pericardium?
Put the needle in it and take it out.
Yeah, and that's called what? Para what? Pericardiocentesis. Paracentesis is of the lung lining, because it's the parietal lung. So sometimes those words are really, really close. So it's pericardiocentesis. Good. All right. We're going to go on to pneumonia because esophageal rupture is going to be very, very rare, and there's only a few things that we're going to mention on that one. So pneumonia, 4 of spades. What is your presenting symptoms? We're skipping all of your numbers. I'm putting you on there. 10 of hearts. Do you have that one? What would be kind of the picture of your patient presenting to the ER with pneumonia?
Cough or sputum.
Right?
Recent infection or hospitalization.
Say that.
Recent infection or hospitalization.
Okay. Somebody else, 2 hearts, give me some more.
Fever,
Good,
shortness of breath.
awesome. Somebody else, 5 of clubs? That's me.
Would they have pleuritic chest pain?
Our big chest pain, and that could be pleuritic or otherwise. What does it mean when they're having pleuritic chest pain?
And they breathe in and out.
Diffuse and should be reproducible. Reproducible as well as, reproducible by what?
Respiration.
Chest compression as well as deep inspiration. As well as deep inspiration is going to cause them to cough. So they'll have a reflexive cough with that. All right. So 2 of diamonds. What oxygen, you're obviously going to go through this. So you've got them on oxygen, you've got them on monitor, you've got some IVs going. What IV are you going to order when you pulled up the chest x-ray and you could already see a pneumonia? What's an empiric antibiotic that you're going to run through the IV? 2 of diamonds.
That's me. I mean, you're gonna do a broad spectrum.
Right, so let's say, yes, they've had a recent hospitalization. So what's that called?
Huh? Oh, a hospital like acquired pneumonia. So.
Which is also called what? Nosocomial?
Oh, right. Yeah.
I didn't know if you guys have been introduced to that word.
Yeah.
Nosocomial pneumonia, meaning hospital-acquired or HAP. And what's CAP? Community acquired. So now we're thinking of bugs that is with this, antibiotics. 8 of hearts.
Do you use vancomycin?
Zinc. Oh, you could do zinc and rosuffin. And rosuffin's also known as, and this is what it will say on your test, your boards,
Ceftriaxone.
ceftriaxone. All right. What on your orders, other than the IVs, and what can you do in the ER before they go to the floor? 10 of diamonds that will help their symptoms. We've already got them on oxygen, so you can't use that one. What would be another treatment that you put them in the hospital for? Other than IV antibiotics? Yeah. What do you want? You don't have to give me the dosage, just give me the drugs. Yeah, albuterol and anybody? Ipratropium bromide, which is also known as Atrovent, so it's your double A's. Albuterol, Atrovent. And that combination. So in your orders you say only albuterol and Atrovent, updraft treatment, Q 4 to 6 hours, pulse oximeter prior and post updraft treatment so that you can kind of see their progress. It helps to loosen things up. The other thing, and I don't know if they've given that to you during pulmonology, would be chest percussion treatments. Your respiratory therapy will be coming in and giving those breathing treatments. Yes, Ryan?
Do you have like a certain pulse ox, like, to be able to order that?
No.
Okay.
Every patient that I've got that has pneumonia, if I'm admitting them to the floor, they're getting that. Because what does that medicine do? bronchodilates. So it's going to help them clear out that sputum as well as dry out, because you're helping give them more oxygen saturation to the lower lungs. And when they're doing their breathing treatments, the respiratory therapist is doing chest percussion treatments, so you're doing CPT therapy. You guys have this during pulmonology?
Yeah.
Okay, it's just kind of a while ago, I'm sorry. And spirometry. That's not the word. What's the machine that they?
Just lists.
That they blow into to kind of keep that bubble up. Is it a spirometer? So I was right. Okay. I know there's another word for it, but it's essentially a treatment. And what they do is they blow into that and they get that ball to stay in there. And what that's doing is having them blow slowly, because they're having to take a deep breath in, and then they're blowing slowly, which means they're holding that air in their lungs. And when they take a deep breath, then they're inflating their lower lobes of their lungs. And so when you're holding that ball at that level, you're keeping that air in there for the longer period of time. And so you're giving treatment to that alveoli to be aired up longer to dry it out. Okay? Because people with pneumonia have chest pain, that's why we're in this lecture. And so they're splinting their breathing, so they're shallow breathing into kidney and not using those lower lobes. And so then they're wet and they're full of crap and fluid. And if they don't inflate those and get air in them and dry them out, it's just going to continue to get worse. So that's the easiest way for me to explain to my patients of why we need to do this, to help them to be more compliant and to help them to know that this is how you're going to help yourself to be better faster. I know it hurts for you to take that deep breath in, and I know when you're trying to hold it and keep that ball there that it's hard, because they want to cough, and they'll cough, and there'll be times it's okay that you have to start coughing and you'll fail. But we'll keep doing this until you get better and better, and that's going to improve your status. Okay? So it's kind of a game. Not a very fun game, but you've got to do it. So your respiratory therapist is going to do that, and you don't usually do CPT in the ER or the spirometer. That's why I can remember the name of it. But you do the breathing treatments, and I forgot to write it down today. So your albuterol, your Activant, or ibuprofen for a matter, which is what it's going to be on your boards. And I do UD treatment, updraft treatment. All right, so esophageal rupture. Four parts. What are some etiologies or causes for you to have an esophagus that just ruptured?
If you,
4 parts?
yeah,
Okay,
if you have esophageal varices that rupture and
good.
form a,
So what causes esophageal varices or gives you a risk of that?
drinking a lot of alcohol and then
Good.
vomiting.
So alcoholics,
Also, probably people who are bulimic and
malignancies.
throw up.
Big,
Sure.
yes,
No.
very good. So people that are on chemo and throwing up a lot, or bulimic and have eating disorders and throwing up a lot because that acid is deteriorating the lining of your esophagus. So you're thinking of anything that's going to thin that esophageal lining. So other people that might have a thinning of the esophageal lining, 4 clubs.
Barrett's esophagus.
Barrett's, right? Yeah, very good. Which people with Barrett's esophagus cause for that? GERD. Right. So GERD. So we've got alcoholics, ETOH. That's how I write alcoholics. Did you guys like my little freebie test question on that? 3 hots a cot. And a tequila sunrise. What was the tequila sunrise? And I'm always serious. My kids say that too. Still alive, aren't you? I go too. Still alive. All right, so alcoholics, people with GERD. So with Barrett's esophagus, which is precancerous, and then malignancy. So anybody that has a malignancy that's causing a deterioration. Yes. So also people that have GERD may develop not only Barrett's but also what? That causes them to have an iatrogenic rupture. What's iatrogenic mean? We caused it.
From a scope.
A scope or a dilatation or intubation, any of those things, okay? So people with GERD or alcohol, all of these patients could have that with intubation or scoping. But dilation, every time they're dilated, they're developing scar tissue, and so then that's thickening and narrowing, which causes it more difficult for you to intubate. Obviously, you're not going into an esophagus, you shouldn't be, so therefore, it's not as high for intubation unless you go down the wrong tube, but more people that are going for GI scopes and that, so they've got to be very well aware of that status going on. Okay? So, what in your lab are you going to order when you've got this patient and you're getting ready to scope them? What do you want to order? 6 of clubs.
PPO.
Good. Do you have a Maxwell's or a Finlay?
Yes.
Huh?
I don't have one either.
This says Hannah. Is this supposed to go to Hannah?
No, she actually donated it back.
Okay. I just want to make sure.
She was the first winner. She declined both prizes. So she was generous and donated it back to your class. Thank you, Anna. All right. So let's go through these slides just to make sure that I've covered everything. Your objectives you can read on your own. Acute chest pain, again, so sudden or recent onset. Just not feeling right. You got old people that come in and they go, I just don't feel right. You better get an EKG. Dizziness, you better get an EKG. They could have had a silent MI and their troponins are elevated and it's not showing up on an EKG, but you've got to document that as well so that you know as far as your acute coronary syndrome, where you're at on that status, or as far as your stable, unstable angina patients. Okay? All right. That's where your pain could be noxious or just an uncomfortable sensation. They don't have to say it's always just here and killing me. It could just be pressure, tightness. Hallmarks though, and patients will still use this, feels like an elephant sitting on my chest. Sometimes they just say my shoulder's been hurting. They used to say left shoulder was hallmark. Now they can say it's either side, especially with a diabetic or a female. Females and diabetics present atypically. So anytime that they've got this area giving them a problem, you better get an EKG. Somatic chest pain, which is always nice, is precisely located and usually sharp. Easily described, easily detected. But then you've got your visceral chest pain, more difficult to describe, poorly localized, dull, heavy, or just achiness. Some people can just say, my arm has been aching. Get an EKG. All right, the I'm going down the slides here. Initial approach, we've already done the A, B, C, D, E. What's D and E? D is what? Which means you need to do what? Glasgow Coma Scale. Good job. Okay. And E? Exposure. Make sure you're seeing everything and you're cutting their clothes off, but you're not cutting through evidence. Good job. Initial approach, obtaining your and interpreting that EKG within 10 minutes. So you're running through that really quick, okay? Physiology of an acute MI, of why, obviously. So somebody that's high risk is going to be hyperlipidemia, sometimes diabetes is a risk factor, obesity, atherosclerosis. So atherosclerosis is being from the hyperlipidemia, building up in the flat of the lining of the vessels, and then it becomes unstable by breaking off and then clogging the smaller coronary arteries, causing an infarction, a blockage. Platelets, once that's thrown in there, if it doesn't block it all the way off, platelets will stick to it as well and continue to develop a clot in that area. That's why you can have ischemia before an infarction. So you can see ischemia. You've got a patient with ischemia that's showing up on the chest x-ray, on the EKG. First thing you want to look at, I've got ischemia in my anterior leads. What do I want to need to make sure of the reciprocal? If you've got ischemia being ST depression, the opposite side of the heart, you need to make sure it doesn't have that elevation. Okay, so that's the one that you're going to do the posterior EKG on. So when you see ischemia, make sure you're oppositely looking for infarction and really looking for that ST elevation, especially when your patient's symptomatic. All right, by definition, diagnosis of an acute MI is 1 millimeter ST elevation in contiguous leads, which means that area of the heart. So the contiguous leads for an inferior MI would be 2 clubs. 2 clubs? Anybody? Anybody? What are the contiguous leads for an inferior MI? ABS. She knew the pattern. You got it. All right. Oxygen, aspirin, oxygen, if their pulse ox is lower than what? 94. 94. Nitro, if their blood pressure systolically is greater than what?
100.
I'm sorry.
90. So it's contraindicated essentially if it's less than 90. I just reversed it, I'm sorry. So anything above that, when your patient's having chest pain, you may give nitro, but you got to be watching it and be ready for fluids and have IV access before you give it if they're close to that systolic 90, okay? If they're 150, 160, 180, it's okay if they don't have IV access yet. You'll go ahead and give them that nitro. But your monitors or your paramedics have already given you what those vitals were. They may have already given it, so make sure that you're finding out if they already had 3 nitro, if they already had aspirin, what dosage did you give? Because even if they say we've already given aspirin, they may have just given 1 baby aspirin, or the patient may have just taken 1 baby aspirin. And what's the indication or the need for treatment? It's 2 baby aspirins. Okay, which is the dosage of?
162.
160. 162 if you do the correct math. All right. So the slide number, and I can't see on here, that has the vessels of the RCA being the inferior 2-3 AVF, make sure you know that slide. You're going to need to know that slide for your boards. So if you've forgotten it when you do your boards the first time, know it. If you've forgotten it before you redo your boards, you know it again, okay? All right. The slide that's got an EKG on it, that's after that slide, there is an acute MI that you need to be suspicious because of the ischemia that's in. Where do you see ischemia on this EKG?
One and
So I see an anterior and lateral. So you definitely need to do a posterior to rule out a posterior ST elevation. And you wouldn't be able to diagnose it with that one. That's why there's still question marks. All right, aortic dissection. The definition, it's a violation of the intima, which is the lining of the intimal and adventitious layers of the aorta. That's why on ultrasound, you see that line in between there, and you're going to get a lecture that shows actual pictures later from an actual sonographer. All right. Think of aortic dissection when you've got patients that are pregnant. You've got patients, so we're looking at, I wish I could see what number of slide I'm on. 13. So obviously hypertensive patients, people that you do a chest x-ray and you see that they've got widened mediastinum, biggie, that's your hallmark. That's what they're going to describe as a widened mediastinum on chest x-ray. So the picture of the guy that's got the line like this, the redness, what's that? What is that guy on that picture? So that is a seatbelt sign, motor vehicle accident. So your Princess Di, impact, your body doesn't stop, neither do all the organs stop when you've got a sudden impact. And so it sheared her aorta, it ruptured that, dissected the aorta. What's the bottom picture stating? Marfan's. So know that, because if they give you that in their history, just be thinking. Everything stretches and is thinner, so is the wall of the aorta. All right. You don't need to know the DeBakey types. I don't know them. I don't believe that I've ever. The other radiograph is showing the X-ray showing the widened mediastinum. Later on, Dr. Lovelace will do a lecture and he'll tell you where is the most common area of the aortic dissection. All right. What? So cardiac tamponade, the post-mortem picture, obviously, of that heart is showing the blood in the pericardial space. That's where you'll be drawing that blood off of. I've done that once in a trauma. The patient didn't live, but I still did it. They were still alive when I did it. I just didn't help. All right. The next picture shows patients, obviously. So the guy with the chest tube hanging out. Look at the bruising that you're seeing over laterally to either side of that chest tube. That's not due to the chest tube being placed. That's due to the trauma. He was in an accident. And that bruising is indicating that he's probably got a hemothorax, which means instead of air causing that deviation, there's blood in that space that's pushing and causing that deviation. And so when you put that chest tube in, if you see that bruising like that, expect a shitload of blood to come out of that tube, and don't freak out. That's what you're treating. You need to get that blood out of there so that that heart and that other lung can go back into that normal space, and then the lung that's supposed to occupy that space may be able to heal. So what's your picture of the girl to the right of the guy with the chest tube? Right, systemic lupus erythematosus. So just know that they are at higher risk for cardiac tamponade. And then we've already had the malignancies that's down below that. What is the other guy? sitting there doing
Dialysis.
dialysis, absolutely. No Beck's triad. JVD, which is jugular venous distension, hypotension, and muffled heart sounds. We learned this in cardiology. You still should know it. And the echocardiogram is the gold standard to diagnose. So, note on treatment, not only pericardiocentesis, but volume expansion. If you pull that blood off of there, you better have enough blood pressure to still perfuse, because that heart's going to be irritable and probably going to be in an arrhythmia. So you need to have volume, volume, volume. Make sure you've got those IVs wide open and volume and fluids going in. The next picture, cardiac tamponade, that is the pulsus alternans that you're seeing on the EKG. So you see how it's spiked, then little, then spiked, then little. It's every other one, up, down, up, down, up, down. All across the board, doesn't matter which lead. And then you've got an ultrasound in the next picture. The x-ray on there is showing water bottle heart silhouette. That's how it will be described in your boards. Know that that is, the answer is either going to be pericardial effusion or cardiac tamponade. And then the next is esophageal rupture. So perforation of the esophagus. That gentleman looks horrible. Anyways, you'll see as his chest is, he's definitely got vascular distension throughout, not just JVD here, but you can see it in the upper chest area as well. Also, sort of food puffer, alcoholic. All right. Essentially, they're saying resuscitation, surgical repair. I'm just going to be calling a specialist and getting them transferred, making sure they've got a secure airway and that they're stable before I'm transferring out due to Impala, and making sure that they've got fluids and pressors and that my transfer team is well educated to utilize those, which anybody on a helicopter is, but make sure by ambulance they will ask you, do you want them transferred via basic EMS or paramedics? Your answer for this case is going to be paramedics, because they're the only ones that can intubate and get a full code and run pressors. You have to have that. All right. We've already talked about this. Iatrogenic causes of esophageal rupture. So there's pictures of them dilating down in the far bottom right hand. You've got, wow, a baby picture of an esophageal rupture. So foreign bodies. The most common, I would say, as far as foreign bodies that we see now, and I've not encountered that, would be those magnets. So magnets, especially because of the polarization, is causing deterioration of the lining. More so, not so much with esophageal ruptures, but more so with perforations of the bowel, because one will be down in one loop and then the other one will be below, and then they'll hook to each other and deteriorate both linings of both of those. Then you'll have free air under the diaphragm and all of those things. Pneumonia, we essentially kind of beat this one with a dead horse. Just make sure that blood cultures for your specific microbiology identification, so you're ordering those before they go to the floor, or you're ordering them to be done first thing when they get to the floor if you're not doing them in the ER. Both are acceptable. So treatment there is oxygen, blood, and sputum cultures. Sputum, not as often anymore. If they can develop enough and they're strong enough and they're not old, elderly, and they're strong enough to produce some sputum, yeah, go ahead and send it off. But again, those are not likely going to give you your answers. Make sure you're ordering those blood cultures. And then the bronchodilators, which is your breathing treatments. All right. Ages of the extremes, obviously, it's going to be your most common, and people that are immunocompromised. So the one with the arrows, that is a wedge-shaped pneumonia, the right middle lobe. The picture of the baby, that's a baby gram. Usually you'll get that because their whole body fits in there. And that keeps you from having to do chest and one view abdomen to rule out any free air under the diaphragm. So you do what we just call a baby gram, and they know just to widen the field to get both of those areas. One view lessens the amount of radiation because it's one picture, one time of radiation dose. Both areas covered. PE, so results when proximal portion of the venous plot goes and is dislodged through the veins to the right ventricle and then goes into the pulmonary arteries. That's why usually atrial fib can cause, but usually with atrial fib, those clots aren't as big, and so they'll go ahead and pass through and go straight through to the carotids. D-dimer says on there for screening, but confirmation with CT angiogram or ventilation perfusion scan. See, so he didn't even know how to answer. He was like, or on that. But angiogram is gold standard. So PE, again, we've already talked about that. So being pregnant, so you've got a hypercoagulable state. We talked about flights, trauma, birth control, and then just a pathology picture. That's nasty. Virchow's triad, know that. Then that deals with PE. So anything that's got a triad with a person's name, you should know those three words. There's the pearl. All right. Dr. Lovelace is going to give you an EKG boot camp, so you'll be able to find rare changes on an EKG to clue you into things like this. I'm not that skilled yet. I will just tell you. All right, pneumothorax again. Air enters into the potential space between parietal and visceral. We've already talked about all that. Oxygen, needle decompression, chest tube. Because the needle decompression is first, you can do that, and then get all your stuff for the chest tube. It's not as painful, and you're relieving some of the stress on the body and keeping them from going into an arrhythmia while you're getting the chest tube, because it takes longer to put a chest tube in. So you can do both. I mean, you've got the needle to put in the ER, and then you're getting ready and doing the chest tube. There's no crime in doing both of those. All right, the rest of those are just pictures. The second set of x-rays are showing the mediastinal deviation to the right. I was just making sure that chest x-ray wasn't flipped. And you can see the actual ET tube is curved as well there. And then you see the actual collapsed lung, because there's absolutely no lung markings on that right lung on the picture to the right. All right, big conclusions. Chest pain is a common complaint. Get an EKG on every one of those patients. You're going to see that daily in the ER, and sometimes daily in your clinical practice if you're doing primary care. Take chest pain seriously. Again, our drug seekers and our people that come in all the freaking time, train wrecks, have real disease and illnesses too. Make sure that you develop a good rapport with your team and everybody knows their roles and you guys talk. Do debriefs after you have scenarios. That's going to help you to grow your relationship. And then making sure we've been teaching this ad nauseum. History and physical exam. Your history is sometimes going to tell you before you even get to the physical exam. Your your history when it's an emergent case like this is coming from your paramedics and the family. And you're running through those and you're talking through it with your team, and you may have to send somebody else out to the family to ask those questions, or bring the family back in if your patient's unconscious, to while you're working to say, I need to know this and this and this. Especially if you run into the fact that you have more questions, multiple questions, and just bring them back. And you can get better care of your patient by immediate answers. Plus, they can see that you're working really, really hard. You're not just all standing there with your thumbs twiddling. Some places, and again, you're going to go off of the protocol of what they feel is appropriate. I've done both. I've worked, when I very first started doing ER, I wasn't comfortable for the family to come back, but then I've gotten into that realm of understanding and being more comfortable the more codes you run, of saying, okay, I know that I'm better off by letting them come back. But you guys will make that decision for yourself. And then the big seven, know all of those, so that you can have them in your head and you're going through that as you're going through the H's and T's. You're running through a code. Any big questions? Sorry I went a little over, but